Good morning. Welcome to day 2. I know you guys have so much fun talking to each other. I hate breaking you up. But we have a fantastic panel this morning. But before I turn it on over to them, we've been getting a lot of questions about PowerPoints from the workshops and also here in the plenary. So there is available on our website all of the PowerPoints. And then also there's QR codes at the registration desk. And then the daily reminder, if you're getting CEUs, you have to be scanned in and scanned out of each of the sessions. However, special case this morning, you just have to be scanned into the plenary just once. And then we're going to be scanning you when we leave at about noon. And then also, for those of you still in the CEUs here, just make sure that you're completing your surveys because that's how the CEUs are tracked. And then the only other thing I want to say is that cheese was great, wasn't it? I mean, I had a lot of you come up to me and say, I went and got the cheese. There were other things. The shrimp was super good too. Oh my gosh. But anyway, hope you all enjoyed the networking. And I really had a great time just talking with a lot of you throughout the day of how much you just enjoy talking to each other, which I love. And that's a really big part of this conference as well. But we're going to turn our attention now to some really incredible county work that is being done across California. And super excited about this panel. I have had the honor of working with each of them for, gosh, I was thinking about it, Veronica and Gary probably ever since I've been in this field. And then Phoebe and Ryan, so many years. And these are just some top experts. So I really think you're going to get a lot out of this plenary. But first I'm going to introduce Gary, Dr. Gary Tsai. He is a physician executive who is the director of Substance Abuse Prevention and Control, which is a division of the Los Angeles County Department of Public Health. In this role, he is responsible for leading nearly 500 staff with a budget of approximately $460 million, overseeing a full spectrum of substance use prevention, harm reduction, and treatment services for the 10 million residents of Los Angeles County. Please welcome Gary, and he's going to take it from here.
Great, thank you, Marlise. Hello, everyone. Very excited to be here today. First, I just wanted to start off with a couple thank yous. I do want to lift up DHCS. Paula had mentioned yesterday that California, under DHCS's leadership, has a lot of first in the nations. And I think certainly on the substance use side with the drug Medi-Cal organized delivery system waiver, the recovery incentive or contingency management waiver, we have a lot of unique opportunities here in California, and I want to acknowledge and thank DHCS for their leadership on that front. And I also want to thank them for their interest in this topic of how we better reach the 95%, how we better reach people who are who would benefit from our services but aren't necessarily reaching out or interested in our services. Last year, some of you may have attended the first workshop where we presented on this concept. Ronnie and Ryan were there. There was something special about the workshop that we aren't really able to put our finger on, but are going to try to replicate this in this broader group here today. Lastly, I wanted to thank our Los Angeles County Substance Abuse Prevention and Control team. I know we have a number of folks here. And specifically, I want to thank them because a lot of work has gone into Los Angeles County's implementation of the R95 initiative. This is obviously something which we took on outside of the various new opportunities and initiatives that are currently in place under CalAIM, payment reform, and otherwise. And so it has added work, but it's important. Fundamentally, I believe that it is central to the work that we do. And so I just wanted to lift up all the work of others that have contributed to what I'll be presenting on today. And so just to outline, we'll start off with an overview of Los Angeles County's R95 or Reaching a 95% initiative, essentially the why, the what, the how, some early data, and then I'll pass it off to my co-presenters to talk about different county experiences in how we are lowering barriers to care across the state. And then we also wanted to take this opportunity just to break out into tabletop breakouts for about 8 minutes or so, so that each table had an opportunity to discuss opportunities, challenges, what they're doing, and ultimately that could help to inform our broader discussion when before we close out. And so just starting out with the Los Angeles County experience, a little bit about the why, right? This is the problem that we're trying to solve. And this is data from the 2022 NSDUH survey. Essentially 17% of people in the United States have a substance use disorder. Just under 15% actually receive treatment over the past year. And of those who do not receive treatment, 95% report not perceiving the need for those services. This is the fundamental challenge that we have in addiction, certainly, behavioral health more broadly as well, although it may be a different percentage. But in substance use, we offer something that few people receive and even fewer people want. And I think it's important for us to keep that in mind and acknowledge that, because that informs the way in which we deliver services, the types of services. It really should inform a lot of the work that we do, right? And this is just another depiction, right? Fundamentally, if we want to think about things in a simplistic way, people with substance use disorders can be categorized into 3 main groups, right? The tiny little circle in the green are those who actually seek out our services. Those are the people who are showing up to our residential sites, our outpatient clinics, our opioid treatment programs. We also have a group in the blue, which is those who are interested but not necessarily seeking out, right? Over time, they hopefully will actively seek out treatment, but they're not right now, right? Certainly we want to engage that group. Then we have the much larger group. And this is really one of the key focuses of the Reaching 95% initiative, which is those who are just not interested in services, right? This is a key group that many systems right now are not necessarily targeting. And there are a couple of reasons why. Obviously, substance use systems are aiming to try to target the entire group. But a few reasons why we may not is because, number one, there are a number of barriers that are under our control, and number two, there are a number of barriers that are out of our control, right? We are working on things to address the barriers that are out of our control. We're exploring some legislative options, but the focus of the Reaching 95% initiative is really around the barriers that are under our control, and really looking through and analyzing all of those elements to figure out how we can better improve them, streamline them, enhance them in ways that will entice, engage, and earn the engagement of the clients that we serve. The other thing that I wanted to highlight with this slide is just that orange group, individuals who are not interested in services, those are individuals who lack voice, right? They're not showing up at our stakeholder meetings. They're not showing up at our provider meetings. They're not completing treatment perception surveys, right? And the reason why is because they don't think that they have an issue, right? And so it's incumbent on us as systems leaders, as leadership of agencies, as staff at agencies on the front line treating clients with substance use disorders, to keep that in mind and deliberately develop our programs and services so that we're touching that group in some way. Fundamentally, R95 is a shift in the way that we think about and approach substance use care. Rather than emphasizing programmatic requirements or criteria, the focus is really on how we better engage, how we better entice people into the services that we offer, right? Which are services that data demonstrates are not necessarily things that they want. And so just a quick question for the group, and feel free to just shout out your answers here. There's two pictures here, right? And these are examples of entities entities that do this well, right? That engage well. Any idea what's depicted here in either picture number 1 or picture number 2? Okay, I just realized I don't understand anything that anyone's saying. I will assume that I heard number 1, pediatric dentists, right? I have a toddler at home. We recently went to the dentist, a pediatric dentist, and when I walked in, I realized this place looks completely different than my dentist, right? There's screens all over the place. There's like stuffed animals on the walls, right? They had an arcade, right? Pediatric dentists know how to engage their clients well, and they recognize that their clients don't want their services. And so they create an environment where kids are more willing. They still don't necessarily want them, at least by my son's behavior, but they're more interested in it, right? Picture number 2 is the Mall of America, right? And why I highlight this is they've done a tremendous job of literally creating an amusement park inside a mall so that people will spend time there and buy more things, right? Capitalism at its best. And it's effective, and it's engaging. And these are the strategies that we're trying to employ to better engage the clients who aren't even clients, right? They're just individuals with substance use disorders who need our services but aren't really knocking on our doors. And R95 is an acknowledgement that what we offer in terms of substance use treatment, oftentimes, not always, but oftentimes, is more akin to dental appointments and taxes than it is to Taylor Swift tickets, right? Let's be real. I don't dislike Taylor Swift, but I'm not that into her music. But I know that there's a lot of people who are really into Taylor Swift. So, thank you. So hopefully this example is hitting. And so last year, the Los Angeles County Department of Public Health Substance Abuse Prevention and Control launched the Reaching the 95% initiative to reach more people with substance use disorders. And we have 2 key focuses. One is optimizing outreach and engagement. 2 is lowering barriers to care, right? And we have a couple goals that we've been consistent and clear on from the very beginning. One is we want to ensure that our specialty SUD system is designed for everyone, right? Including the 95% of people with substance disorders who are not interested in treatment. The second goal is really to lower barriers to care in the hearts and minds of not just the SUD community, everyone here, but also the public, right? There are a lot of ways in which we have trained the public to believe that if you're not ready for complete abstinence, you're not ready for treatment. We are moving away from that because we believe that there are people with substance use disorders, and the data demonstrates this, who are not interested in complete abstinence right now. Maybe they've cut down from 5 days a week of drinking or using meth to 2 days a week, right? And if they're interested in services, our job is to say, yes, we're gonna do everything that we can to get you in the door, as opposed to saying, please come back when you've hit rock bottom or when you're more ready, right? And one of the examples of this is, we do this all the time in different areas of healthcare, right? For people who have diabetes, if you show up at your primary care doctor for the first time and your blood sugar is 600, right? Your primary care doctor doesn't say, come back when you get your blood sugar under control and it's under 200, because then you're committed to treatment, and then we can help you, right? Your primary care doctor probably says, oh my goodness, why did you not come in like 6 months ago? We're going to make you an appointment immediately, right? And so this is what we're trying to do, right, in terms of retraining ourselves, the community, around what readiness to treatment means. It's also important to highlight, we are in the worst overdose crisis in history, locally, nationally. Rock bottom is unfortunately death, right? And so we can't afford to continue to take that approach. The last goal that we have is really to communicate in words, policies, programs, actions, that people with substance use disorders are worthy of our time, attention, resources, and compassion, right? No matter where they are in their recovery process or their readiness for change. We want to demonstrate this, right? And then before I get into some more nuts and bolts, I did want to just share a personal aspect because, and those of you who I work more closely with are already aware of this. You know, I was thinking about why does this initiative, at least in my mind, the Reaching the 95% initiative, feel different for me, right? Because I've been involved in a lot of different implementations, projects, initiatives, et cetera. And I realized that, you know, one of the main reasons why I became a physician, a psychiatrist, why I chose to work in an administrative position is because I grew up with a mom with schizophrenia. She didn't have any substance use, but my family had a lot of challenges getting her care. And those challenges were not clinical issues. It wasn't that we didn't have any good psychiatrists in the community or great social workers in the community. The system was designed in a way that blocked her out of the system and made things much, much, much more difficult for my family to receive services. And when I think back, I mean, there were a lot of painful days. I remember crying myself to sleep on, you know, many nights, right, when I was a child. The reason why and I know many of you in the room do the work that we do is because we fundamentally want others to avoid going through some of the pain that we've been through. And, you know, for me, I think that's one of the reasons why Reaching the 95% is so meaningful. It's about how we create, design, curate a system that avoids those challenges for as many people as possible. I'm real. I recognize that, you know, we're not going to create a perfect system. But if we can deliberately focus on some of the key issues that are resulting in those challenges for people with the conditions we care about and their family members, we will make things better, certainly over time. And so with that, I'm going to dive in a little bit to some of the focuses, because I think today's session is about sharing the concept, right? It's also about providing some very practical, hopefully actionable information for systems, agencies, organizations to consider with respect to the work that they are doing. And so we have 5 focuses of the R95 approach. This is basically the how, right? Number 1, in terms of optimizing outreach and engagement, we've, as a part of our payment reform approach, incorporated R95 in and are incentivizing the development of engagement and outreach plans by our network, right? So we're essentially paying them to develop some plans to define how their agency is going to improve outreach and engagement for the clients that they serve, and also for the clients that they want to serve but aren't, right? We're also focused on maximizing the ability for us now to engage people prior to a full assessment. We're incentivizing MOUs with partners just to better identify when individuals that they're engaging with, even outside the behavioral health system, may benefit from services so they know how to refer in. And we're offering radical hospitality trainings, right, for our provider network, which is really just about how we can enhance customer service, right? They do this in a lot of different sectors outside of healthcare, something that is beneficial to employ within healthcare as well. We're also growing our field-based services. This is obviously an exciting allowance that allows us to spread our tentacles across the community. We're looking to maximize that. The third focus area is around what we call service design. This is incentivizing our agencies to do customer walkthroughs so that they better understand from A to Z what their clients are going through when they first come in the door, when they go through treatment, and when they ultimately leave services, including if they're being care coordinated, hopefully, to another level of care outside of their doors. We're also prioritizing focus on how we can create more welcoming ambiances for the individuals that we serve. This is where we get into things like lighting, right? Softer, white, warm lighting, matching furniture, right? All these little things that, I wouldn't say is the most important things that we do, but is an oftentimes underappreciated aspect of the services that we offer, and definitely inform people's impressions before they even start speaking with any of our staff, right? These are the things. We're looking to enhance people's interests in our services by small amounts to try to get as much of an advantage in this battle to engage people as possible. Number 4 is around facilitating bidirectional referrals and integration of harm reduction approaches into treatment. And I think this has been an area that has been particularly interesting. We're doing regional listening sessions throughout Los Angeles County to listen to our agencies and in particular frontline staff. There have been a lot of fruitful discussions and conversations that have resulted from this. I would say that a lot of them involve us nuancing what we mean when we talk about an R95 approach, right? Because for us, R95 is about supporting recovery in different ways, right? And sometimes we hear, why are you not supporting abstinence, right? And I would say R95 100% supports abstinence. What it does is it also says that that's not the only thing that we support, and that even if someone's not ready for complete abstinence, we want our doors to be as wide open as possible so that they know we will be there, right? Number 1, they can come in now, and we will continue to be there. The 5th area, the last area that I'll focus on in terms of R95 is lowering admissions barriers and addressing discharge policies that are consistent with engaging people in services. And so when we started this process, there were different options we considered. Where we landed is essentially we've drafted admissions and discharge policies for our agencies to adopt that have required language and then indicate areas where agencies can tailor additional components of that policy to their specific agency, right? This gives us an ability to ensure that there are relative consistencies around admissions and discharge policies while also giving some flexibility. One of the key changes in terms of admissions policies is not necessarily requiring complete abstinence before someone's admitted into services, right? One of the key changes in terms of discharge policies is not automatically discharging individuals when they return to use or lapse, right? These are common practices, not just in California, but nationally. These are things that we think are deserving of relooking at in order to lower the threshold for services and try to retain as many people in services as possible. You can see some of the specifics in the boxes below. I'm not going to read through those for the purpose of time, but I think you get the sense of kind of what we're trying to do in terms of lowering admissions bars and raising discharge bars. I presented on this yesterday in terms of payment reform, so I'm not going to go into significant detail, but just to highlight, we know that financial incentives can drive practice. And this is the reason why we've incorporated the Reaching to 95% initiative into LA County's payment reform approach within our specialty substance use system. And so R95 is built into our capacity building funding opportunities. It's built into our incentive opportunities. I would say it's also built into the approach that we've taken to building our base rates, because base rates are the foundation of the services, the financing of the services that we offer, and we recognize we want our base rates to cover the full spectrum of services that we're hoping our agencies can offer. And then just moving towards closure. We've implemented this, I mentioned last year, so we've had about a year to implement. We're still analyzing the data that we have, so this is early. But key takeaways, about 85% of our specialty SUD treatment network in Los Angeles County has participated in R95 in some way, right? Basically, they've signed up in at least one of the various components. Over 50% of our network are what we call R95 champions. These are agencies that have committed to implementing at least three specific components of the R95 initiative. And you can see, broken down into the different categories of R95, the percentage of agencies that are participating, and some of the concrete MOUs, policies that have resulted as a result of their adoption of those components. And so from this, you can also get a sense that R95 is not one thing, right? And R95 can also look differently in different counties, in different organizations. But what's most important are those central tenets of really focusing on how we can better engage and earn people's buy-in and engagement. In terms of outcomes, again, it's a bit early for us to specify from a quantitative perspective, but in terms of trends, since we've launched, we've seen increases in new admissions, we've seen increases in unique clients served, which is a key outcome that we will be paying close attention to because the end goal is to increase the unique clients served. We've seen decreases in terms of clients discharged for cause, and we've seen increases in treatment retention across the board in every one of our levels of care. Also want to highlight that, thank you. This is not an effort that will deliver immediate results. You'll see some immediate results, but this is more like, how do we solve homelessness, right? It's things that take time. How do we solve the workforce shortage that we've been experiencing for decades? It's not something that within a year we're going to expect to see a 50% increase and say, this is why we need to continue to do this. And so right now we're paying attention to trends. We anticipate that there will be a snowball effect, right? And that snowball also involves all of you in terms of understanding, hopefully buying in, adopting, being convinced about the merits of these lower threshold approaches to care so that we can implement these more broadly and this becomes more mainstream. I would highlight SAMHSA released about 6 months ago a low barrier advisory to substance use care. ASAM is in the process of releasing clinical considerations related to how we better serve non-abstinent clients in substance use services. And so this is a direction that the field is moving in, right? I don't see this as a fad, but more I see this as the future in terms of the direction that we're moving in. And then lastly, before I turn it over to Phoebe from Nevada County, just some qualitative quotes that we got from some of our provider agencies. Obviously, there's two quotes here. I'm just going to spend some time on one. And I want to spend time on this quote because this is an agency where if you have these conversations in your organization or in your county, you will likely run into some resistance or concerns. And this was an agency that had a number of concerns when we started out, right? And as they went through this and approached it with an open mind, this has been their experience. After reflection, it was apparent that the industry-wide practice of screening out clients not interested in abstinence from services not only harmed those who lost their chance at an introduction to recovery, it also perpetuated the industry-wide myth that if all clients remain sober, the quality of your treatment program has been proven. Taking that easier position, we failed to take on the true work of engaging and helping people who may be more challenging or who possess different goals and values. R95 has become a moral and professional direction for us, part of our reimagined mission. This is one of the examples that we talk about with our network when we talk about seeing agencies experience what we call a light bulb moment, right? Where after all of the meetings that we've had, there's this light bulb that goes on where they start talking to their staff and their leadership and their management team about what this means and how this impacts the services that they offer. And my hope is that folks today will leave with a general sense of that, maybe not a light bulb moment, but just even a glimmer. Feel free to reach out to me or any of our team at SAPC if there are questions. I want to also highlight, we do have a website for our Reaching the 95% initiative where there's already some information, but we're in the process of posting more operational information for counties and organizations that are interested in implementing this and providing some resources for individuals and groups to do this. And so with that, thank you very much. I'm going to hand it off to Phoebe Bell, who is the Director of Behavioral Health from Nevada County.
Thanks so much. Thanks so much, Gary, and I'm really excited to be a part of this conversation today and hopefully also bring a little bit of perspective from a smaller, more rural, and slightly less well-resourced county. So to contextualize a little bit, because I'm going to hazard a guess, many of you have never been to Nevada County or maybe aren't even sure where it is. First news flash, we're in California. Which is definitely a surprise to the many people from Las Vegas and Reno who call us regularly looking for services. Second fun fact, it is apparently not a coincidence that that red blob there, which is us, is very much in the shape of an old-fashioned pistol called a Derringer with the barrel pointed right at Carson City, Nevada. There were some very heated struggles over naming. City of and county of came before state of, and thus the county lines were redrawn, apparently, into this lovely arrangement. Though I do want to acknowledge that these name struggles came in the aftermath of the genocide and displacement of the Nisenan and Washoe and other peoples who lived on this land for generations prior to the names of Nevada showing up. Last fun fact, a very, very famous dinner party happened in our county. Anyone happen to know the name? Quick hint. Donner Summits in Nevada County divides our county. It can get a little wild up there, as the Donner Party might be able to tell you. So, some slightly less cool things about Nevada County, and I am having a moment of vulnerability because I'm going to highlight some of the things that aren't going great for our county, and so if you have DHCS in your email address, you might want to cover your ears. So we have an above average rate of people experiencing homelessness in Nevada County, which is surprising because I think we typically think about homelessness in an urban setting, and also upsetting because we know that the California rate is not low to begin with, so to be above average is not excellent. We have one of the highest suicide rates in the state, which is kind of par for the course for rural, mountainous areas, counties and states around the country, but very upsetting nonetheless. And we have really high overdose death rates, again, well above the state average. Those have started to level out and come down, but alarming nonetheless. And when we took a deeper dive into our data around our crisis system and around our overdose data, we really found an overrepresentation of people experiencing homelessness in that data. And so for us, when we think about reaching that 95% that Gary is talking about, we really grappled with some questions around who are we not reaching, who is most vulnerable, and what do we need to change to better reach those folks? And for us, our kind of top priority population was reaching people experiencing homelessness who are also struggling with substance use and mental health needs. That was clearly what our data is telling us is kind of the most gaping wound in our system, really. So what do we need to change? And for us, it's really about changing how we used to do things. Not that long ago, we basically, as a system, had lovely clinics. We had really wonderful staff who came to work every day, and they'd come to work and flip that open sign and be prepared to greet whoever came in the doors. And when they came in the doors, we were going to meet with them and talk to them and see how ready for change they were, see if they're in the right place to really be deserving of treatment, and then dispense that treatment really as a reward for that good behavior. And in fairness to us, this is really a reflection of a deeply underfunded SUD system, particularly pre-ODS, that very coveted resource of residential treatment, which is pretty critical for many people who are unhoused. We didn't have funding for it, and so with those limited resources we have, we really triaged, and align those resources where we thought it would do the most good. But changing that way of looking at the treatment system is a big shift. There's deep roots to that perspective, again, grounded in some practical reasons, but that need to change. And so what does that look like now? It's really, like Gary was saying, it's all about that outreach and engagement, that getting out there and greeting people. And just a quick aside, there's some pictures in here of what homelessness looks like in Nevada County, and I share those because I think sometimes we forget that in rural counties it looks really different. Tents might look the same, but you'll notice the backgrounds are forests and meadows. You could drive down the roads of Nevada County and not visibly see people who are struggling with lack of housing. You have to go deep in the woods to find folks. And so that's what our teams are doing. They're out there walking through the woods, going to camps, talking to people. And when they get there, the focus is on basic needs. It's on what that person wants today. And that might be dog food, it might be cold water. I'm pretty confident it's not going to be an SUD assessment appointment. And so we start where we're at, and we start building that relationship. One of the things we do from the beginning, though, is really weave in that harm reduction approach from the get-go, harm reduction supplies and conversations. And I think that's important for a couple of reasons. First and foremost, it acknowledges from the get-go, hey, we know substance use is happening here. That's not deterring us. We're still showing up. We still care. We're still coming out here. And secondly, what we care about is keeping you safe. We want you to be okay as a human being, first and foremost. And here's some fentanyl test strips to help with that. Here's some tips about what we're hearing about the drug supply on the streets right now. And that's where the conversation can start. We really want to build that connection and that relationship. In kind of program level, what this shift is looking like for us is that we are doing a whole bunch of things we didn't do 5 years ago. So that outreach, homeless outreach team originally was an innovations project. We moved that over to enhanced care management team. That's where the funding stream we're using at this point. Pros and cons to that model that I'm happy to talk about elsewhere, but that's helping keep that kind of way upstream, getting to know you work going. We applied for B-CHIP funding to buy a building and rehab it into like a day resource center, essentially. So we're adding showers and laundry and all those kinds of things, but also treatment on site. And we'll be standing up a low barrier MAP program there with one of our providers who's here today. And really having access to virtual prescriptions whenever somebody walks in the door. We're using our behavioral health bridge housing dollars to really prioritize this population and try and address that like most primary need of all, which is a safe place to sleep at night. And we're a recovery incentives pilot county because we have really high methamphetamine use disorder. And all of these programs and projects are amazing. I am beyond grateful to the state and DHCS for all the investments that are happening right now into our system and the ways we can align those resources to kind of meet this moment and do the work that Gary's talking about. But I also really want to underscore that a program is kind of nothing without the people involved in it, and that's the people on both sides of the equation. And I think sometimes we forget about the intangible part of this work as we look at metrics and quantities of people served and access criteria and things like that, that the work is really, really, really hard on a daily basis. The people we're trying to reach in this work have experienced incredible amounts of trauma, wild amounts of trauma. They're deep in survival mode, and it's rarely as simple as, I went out, I met someone, I offered a service, they said yes, and we both went on our happy ways. We all know that's not what it looks like. And yet, we keep doing it and we keep trying. And I really, as we're gonna in a sec see a short video, but that tries to capture some of this, but I really wanna highlight the courage of our staff, many of you in this room, many of who are out in the fields today doing their job, who day after really hard day keep going back out and going for that 35th time of working with that person and bringing that cold water and trying to build that relationship. But also, more importantly, the courage of the people we're serving who really have every reason to feel hopeless, who feel pretty broken by the world they've encountered to date, and who nonetheless one day might be brave enough to take that step of leaning into the hope of possibility.
I'm Beth Kemplin. I'm a lead care manager for the Enhanced Care Management Team of Nevada County Behavioral Health. I have this unique perspective as someone who has a lot of lived experience. In my teens and 20s, I was unaccompanied youth, a runaway. I was by myself from the age of 15 on, I have experienced many of the challenges that our folks experience on a daily basis. I just feel like I get to bring that to people and let them know that I really understand where they are, and I know that there's a path. There's a path, and we can find it together.
So tell me a little bit about your story, Sam.
My story is I started using my drug of choice, meth, when I was 12, and just kept using. I'm 34 now, so it just progressed. And
What point in your story did you start to feel hope, though, that things could be different?
I was started from jail to treatment and started to get hope there, and then from treatment to tea house. And it was, overall, I started to backpedal. That last relapse, I just kind of surrendered to everything that I was being taught but wasn't putting into practice. And immediately just things started to get better. I feel like the support's always there, but it's how I receive it and if I want it. There's times when I've had a whole group of people to support me and I just wasn't ready yet.
What tips do you have for us, for people who are trying to help someone who's struggling?
I feel like that if there can be some more outside resources to go into outpatient and kind of like either for jobs, for resumes, or for certain, just any kind of resources, housing, like. So I just celebrated a year clean off of meth and heroin, and I want to go to beauty school. That's where I want to see myself, is just trying to think bigger for myself instead of settling.
Brendan Phillips, behavioral health program manager for the enhanced care management team. So the most difficult challenge is to bring hope back to any individual person's, like thinking that like there's a day that's going to look different than today, and that'll build, and then lo and behold, after lots of good engagements, you get to the place of that person feeling like, okay, like I can see something more than the crack in the pavement in front of me, whatever. It's really hard to hold that and to see people repeatedly come back to that feeling of hopelessness, but always having to be there, showing up, trying to bring hope back to the situation. I think that's the biggest challenge that we face.
Yeah, I think just remember to make space as you think about doing this work for that piece, for the hard human heart work on both ends of that equation of holding hope and being willing to think that hope is a thing that might be possible for you. So I think lastly, really quickly, as we kind of keep moving down this path as a system, there's a ton of challenges still that we are trying to figure out and work through. We do not have this all figured out at all. From the sort of deep-seated helping nudge our system down the road of looking at things differently, to the realities of housing people in, whether it's interim housing or treatment housing, who are in different stages of recovery is really, really challenging in real life. Not having enough housing is now our scarce resource that we triage out, and that's really, really challenging. So lots of complexities to this work, but it's incredibly important work, and our goal is to have those initial really poor outcomes start to look different as we head down the path. So with that, thank you so much. I'm going to turn over to Ronnie Kelly.
All right, so Ryan's told me I have 3 minutes because he wants to do his full 12, but that is not going to happen. So,
we do have a question on that, though, because there's this clock up here that's telling us 15 minutes. Is that a true statement this clock is making?
okay, good. We're just going to keep going.
We can just do whatever we want?
That's always exciting.
Yeah.
Okay, good.
All right.
All right, very good. So, as we've been talking about up here, I mean, we all know change is super difficult. And we have great theories for change management. We know about pre-contemplation when folks aren't maybe ready, contemplation, preparation, action, and maintenance. But change is still hard. And it's always important, I think, to remember that all addiction is complex, all of it. In Orange County, 3.2 million people, we're just south down the 405 freeway. We are 3.2 million people, like I said, but about 1 million of our residents are on Medi-Cal. And if you think about the housewives, and that's your idea of Orange County, a third of our population are Medi-Cal beneficiaries. We have a big problem in our county, and we have a lot of money, but it's not in the treatment space, so it's important to remember. Because I'm going to talk about why is this a problem for us in Orange County. So we began drug Medi-Cal services and organized delivery system very late in the game, and we're really conservative by nature. Our county is conservative, and so while we might want to change our macro system, for all our social workers out there, the big system is not changing. And that's an impediment for all of us to try and hit that 95%. Because what that means is if we start to focus on change and on recovery, that means that I'll have to change some stuff, me as an Orange County resident, right? That means that maybe I'm gonna change some personal stuff, and maybe my dad, who I thought just was always an asshole, maybe he has a disease. And maybe the reason I'm the way I am is in relation to that disease. And maybe that changed the narrative about me if this is an actual disease. Changes my story. So that's difficult. And then like many places, NIMBYism, not in my backyard. Folks in Orange County, like in many of your places, including Nevada and Riverside, and of course LA, work hard. And they want to keep a nice neighborhood. And they don't want it to look a certain way. But they don't want people to die of overdoses. And they don't want people who are unhoused on our streets who are using in front of them, right? But that's the environment that we're trying to do all this changing on. And so if our focus is, how come 95% of people who need treatment aren't coming to us? Then we are missing the forest through the trees, right? Why don't we want people to get care? Because it is about that. It is about our environment and all of the things that all of us need to be doing. I mean, that's further reinforced by Orange County's commitment, unfortunately, to dismantling our rehab Riviera. So that's where along the coast, folks buy up houses, they have beautiful places to recover. That's where I would want to recover. But those are businesses, and not all of them are bad, but the ones that are really bad, man, that ruins it for all of us. And when we looked, the grand jury in Orange County did a report, 22-23, and it looked at these sober livings, right? It looked at SLEs. And what it found was that the biggest concern communities had were these nuisances. So think about this. People are dying, and this is the concern of even probably some of our staff who are here, and myself. These are the concerns. There's too much foot traffic. There's too much traffic overall when there's a SLE in your neighborhood. There's too much noise. This one I love. There's vomiting in driveways. I'm pretty sure that most of us have had vomiting in our driveways and there was no SLE in our neighborhood, right? That there's an increase in street parking. That's why we don't want these things in our neighborhood. There's an increase in trash, and my most favorite is that people are relapsing in public. This is the very real backdrop of the environment we are all working in. And so we want to know, well, how come you don't want to come in and get treatment? This is the reason. This is part of it. How do we dismantle that? Stigma. When we have these drug crises, so crack, and then cannabis was a thing, and then we went into all of our synthetics, and then opioids. Absolutely, there's concern. In Orange County, huge concern about that. But what we've seen is that stigma is still there, and what we're seeing in Orange County, I'm sure like many of you in the nation, we're seeing that increase in stigma. It isn't getting better, it's sometimes getting worse, and maybe that's related to political figures, but even some of our elected officials in Orange County who love this space, they want to help. They will say things at our events, like our fentanyl town halls. We do town halls all over Orange County trying to get the word out and about Narcan and Cloxato and such. And we'll have these really well-meaning people say things like, now, these aren't drug addicts. These are your kids who are dying. That statement is like a knife in your heart, at least it is to me. No, everyone deserves to live, especially drug addicts, especially drug addicts. And another part that makes really this all difficult is money. It is really hard, as my colleagues have stated, to treat something. In this state, in our nation, we have parity, but we all know that does not exist, which is unfortunate. We can't pay our workforce enough for the work that they do, the life-saving work that they do. Our relationship with our providers, especially because this is a workforce that's 35 to 57% people in recovery. And these are folks who are completely focused on recovery, helping people get to that place. But the issue is, we, again, still are not asking this question of the people we're trying to serve, right? We're not asking them, so how come why aren't you interested in all this great stuff we all talked about that we have? And we're always focused on that 5% who can find us, but again, the 95 who don't give a crap about us, that's the place we have to go. So I think we have to contemplate, as has been stated, our treatment standards. And even though many of us do focus on harm reduction, our system really is built on abstinence and on some punishment and negativity and, quite frankly, moral failing. It's still there. It is right underneath. And I think it's really important to remember that when things are institutionalized, like our stigma is in addiction, that just because we have science and research, that ain't a magic wand. That doesn't go away. We have to really work on this to change things. We truly treat addiction differently than we treat every other disease. When our mental health partners, and I'm a mental health clinician as well, when we borrowed the idea of peers from 12-step, from fellowship, and really focused on addict helping addict, sort of. We didn't do a great job about that, right? We stole the idea, but if you look about how we do it on the SUD side, we could really improve there. We do a dismal job, I would say. We have people in recovery who are working, but we aren't using people who are in recovery to do the actual work of peers. I don't know why it freaks us out a little bit, but it does. To focus on the 95% of people who don't seek or want care, we really have to go to the front lines. And that means we go to people who are using fent. We go to people who are actively using now. And Gary pointed it out, like, they don't come to our focus groups. You all know someone, right? We could certainly, we use contingency management. We could certainly get folks to come and talk to us. Now, we're not going to give them cash, absolutely, but we could feed them. Right? In custody, all of you have an audience right there. 80, 90% of those folks, you could find out for real. Thing is, I don't think we want to know. Our ASAM and our psychosocials are giving us some information. They ain't giving us the stuff we need. And we have to go to people. And we've, I think, tried to professionalize this space so much that we're forgetting where we came from. Thank you. And so think about it. Why do people still use? Okay, yeah, they don't want to be sick. That's why they're using, right? They don't want to be dope sick. They can't stop using. But maybe we need to be more creative in how we treat. And so treatment options. Let's think about psychedelics. Could these be more of a treatment option for folks? And I want you to stop and check yourself. What did you just think when I said, let's use psychedelics to treat addiction? Some of you said yes. Very good.
I liked it a lot.
Some of you said, well, that's treating drugs with drugs. Hello. That's what we do, right? There are different treatment options. If we are sticking to this very specific way of treatment, we ain't going to get that 95%. We might get 6, we might get up to 7. We are not getting 95. So why are we not using? I know why we're not using it, but think about it. Philosophically, why are we not using ayahuasca, psilocybin, ibogaine? We have so much research on these agents. Yet, here we sit. And I have a thing on there about getting creative with opioid abatement dollars. Y'all got opioid abatement dollars. Most of our counties, I think all of them, right? DHCS got them. And so we got to get creative with that. I know in Orange County, I have so much opioid dollars. I don't have any elected officials in here, I don't think. But in Orange County, we know, because our manager there, our director over substance use disorder, Mark Lorenz, knows. We're always asking. We got like, I don't know, $24 million I'm sitting on. We cannot get it out. Why? Because the rules for the abatement lawsuit are really crazy. We can outsmart lawyers, come on. So we have to be more creative about that. We're talking about maybe we do a bundled rate. You provider who we don't usually work with in DMC, you say $1,500 a day is what you'll pay to provide everything for this individual. I'll use my opioid abatement dollars for that. Not drug medical. I can get people in quicker. I have to do something. We have to do something different than what we're doing right now. Because then I go back to that 95%. What do they want? So I'm going to talk now a little personal. I'm going to try and get through it because it's kicking me under the table. You all can't see it. But I want to talk about assumptions we all make. Okay, I'm a mom and I'm a clinician. But when my kid was diagnosed with an opioid use disorder, I knew family history. I knew that was going to be there, possibly. I hoped it wasn't, but there she was. I assumed that my kid would want to get better. I assumed that she wanted less problems in her life, that she didn't want to have the shit beat out of her by her boyfriend on the streets. I assumed that she wanted to come in out of homelessness. I assumed that she didn't want to be dope sick. I helped get her treatment. I used my insurance, my good county insurance that really sucks. I scheduled her intakes. I considered kicking her off my insurance so she could get drug medical. I took her to her apartment, or to her all of her appointments, but it didn't dawn on me, like, man, what does she want? And also, think about our system, we're super paternalistic. We don't want to be, we can say maternalistic, let's do maternalistic. We don't want to be, but we are. We all of you carry the water for your loved one and your patients. The thing is, maybe they don't want to carry the water. We just keep carrying it for them. I'm going to now show you, tell you a little bit more. This is going to be a trigger warning. So that kid of mine, when she was 20, in and out of treatment, came home. She was on naltrexone. And I went and got some Narcan at CVS. That was a whole different story, but he won't be able to talk if I tell that story. So I got Narcan. I had it at my house. I said, this is where the Narcan is, to my other two children. Devin, my daughter, came home about 2 in the morning. We were talking, having a good conversation, but I'm, Mom, hey, man, it's 2 o'clock. You shouldn't be out this late. And as she's talking to me, her eyes are slowly closing. I'm like, you see, you're so tired. At the same time, her 16-year-old sister's with me taking pictures of this because she's like, oh, good, Devin's going to get her ass in trouble. I'm going to document it all. I take Devin to her bedroom, and I lay her down. Now, that's Devin on their mouth open on the right side, I guess, for you guys. As I'm laying her down, all I hear is like a machine sound of her breathing, and I knew what that was, that she was probably in an overdose. Her drug of choice, heroin, when she couldn't get that, fentanyl, and also using Xanax on top. I called for my kid, drop your phone, stop taking pictures, get the Narcan. I called 911. Had to calm down the dispatcher because it's a young kid and he was very, very nervous about things. I'm trying to walk him through, take a deep breath, calm down, and then initiate the Narcan. Our Huntington Beach paramedics right around the corner came and picked her up, and then that's her on the other side where she's in the ED receiving intravenous Narcan. But it's important to remember that recovery happens, why you all are doing this work, why we all do this work. She got pregnant, thank God, because that saved her life. Her and her boyfriend there. Her and her boyfriend there on that one, so you can see where she is with her boyfriend, both decided they would get it together, and that this was something that this is what now she wanted to do. She delivered a drug-free baby in the middle there. So that's Johnny Kelly Meador, and he will be 5 years old at the end of September. And then that's her with him there, super happy and excited. She is in recovery, and she's here, and she doesn't like to ever have me point her out, but when you have a mom that's like me, this is what you get. So if you wouldn't mind, Devin, could you just stand up? I want people to see that you're alive and well. So I asked her, because she's been the 5% and she's been the 95%, sometimes at the same time, right? And I asked her, why didn't you want to get treatment? And she said, because it was scary. She said, because I'm used to this, I'm not used to that. She said, providers don't treat me with respect. I'm going to let that sit there for a second. Even for those of us who are in recovery, we have a tone, we have a look. We're human beings. But if you're not respected, you ain't going to do it. You aren't, because that just reinforces what you already thought about yourself, right? That you are not worthy. And everyone is worthy of recovery, everyone. Now, and two, she did say the thing that's most helpful is that she's got a great counselor that she sees at her narcotic treatment program, great counselor, because he's in recovery himself. And so she's even told me, like, these are things we talk about in session, and I've thought in my head, because I'm her mom and I'm a clinician, well, it seems like he might have some boundary issues. Maybe he should go get some more training. And then I have to check myself, right? It seems to me, I'm not a person in recovery. It seems to me that I should stay out of this. If this is working for my kid, it needs to work. And so, how do we change? We got to shift, right? In Orange County, for those of you who, well, I'll tell this in a little second, providers have been our focus. We need to get more and more providers. But you know what? Maybe we need to not focus on that, get more people into treatment, right? We need to focus on that, the 95%. We can do focus groups, like I said. You don't call them focus groups. You call them something else. You all know people who we could gather to do this, and we have to start doing this. Do key informant interviews, people in early recovery, to see where they struggle, right? Because we do not know it all. Science doesn't know it all. Sales I have on there. So for those of you who saw us last year, I talked a lot about how I have to go out on a bunch of dates with providers, and I don't mean that literally. I just mean try and entice providers. Come into the DMC system. People do not want to work with us. But we have changed that. We went from being in the having in the high 100s, that many residential beds, to 220 residential beds. So we're working. It's hard doing all this dating. But I think we really need to focus on that 95% now, right? Politics, super important because the struggle is real. We are all living in the political place right now. Even elected people who I have helped actually get their kid into actual treatment still support anti-treatment policies, especially in Orange County. And we have to change that. Bias, we have to address the bias and the stigma. Start with yourselves. You all know what's going on in your head. Start with yourselves. I mean, I constantly have to check myself, constantly. And I grew up in a family of addiction. And I have a kid who's in recovery, but you've got to check yourself. And I think one of the best ways to do this is to tell your story. So you get it out there. I know so many people, especially when I came to Orange County, no one wanted to talk about their stories. And we need to. We need to share this with people, right? My story is no different than any of your stories. My kid's story is no different than any of your stories. That will help minimize our stigma. Because part of decreasing shame is we have to be really honest, we have to be real. If it works for you, work it. There's all those sayings that 12-Step Fellowship uses. That's not just a bunch of cheesy stuff that we used to put on bumper stickers. It's not, right? I think it's important we're honest with folks as well. This is hard. This is not, oh, come into treatment, cured, that's it, you're in treatment. This is hard, and if we don't tell people that up front, we have set them up. We need to do that, right? We can be the best clinicians ever, but we don't do the work. Our patients do the work. Again, it is hard. But it's worth it. I think most of you in here would say it's worth it, and we have to share that as well. And then crisis, never let a good crisis go to waste. Whenever there's any kind of crisis, we pounce on it in Orange County because that's the only way I can get people to move the needle. Sorry for that reference, but it's really the only place I can do that. I think it's important that while we're really focusing on the 5%, we want to keep them, right? We want to retain them in treatment. We have to really broaden our views, take a good look at ourselves, and start to try some different treatment options. We can figure out the financial piece. While DHCS works with CMS on this, we can figure it out. You've got opioid dollars. Be creative, because recovery is important for everyone. And thank you.
So hard acts to follow up at the table. 6 minutes, Dirty Fresh is on. So I've got a secret text that says we have a little bit of time, but I'm still probably going to go at a high rate of speed through mine. So we maybe can still fit in that 8-minute table talk. We shall see. Those of you that are in our session last time know a little bit about this team, but this is our behavioral health navigation team. Started out as a SUD navigation team only with 1.5 FTEs paid for, and is located inside of our county hospital and emergency room. But a couple things to connect here before I give a little history. I feel strongly the stats on the screen speak for themselves, but I will explain a couple of them just to connect things. But I want to go back to yesterday's plenary session, and when Dr. Gallium, Paula, and Tyler, and Marlise is singing, really set the stage for us through this in the way that I see it. One thing Paula mentioned was the stigma and the breakdown between what other entities think about us as a workforce, and that I mean mental health, physical health, substance use. And this team has absolutely crushed that stigma, and I'll explain a little bit about how they did that in a second. And then Tyler talked about harm reduction and patient-centered care, and again, this team takes that to a whole different level. And so when we talk about the history of it, I said it started small. I'm going to fast forward to what it is today. They are now working with 8+ staff. It's a combination of AOD counselors, peer support specialists, clinical therapists, and case managers wrapped around patients that are in our hospital emergency room. Whether or not they come through the ED Bridge program and they're getting inducted on some bupe and moving up to the inpatient floor, whatever that looks like, this is where they work every day. And at first, with that 1.5, human beings, obviously, too, working in there, it was very different, and the medical staff didn't know what to do with us. And I can tell you now, fast forwarding since July 2021 to today, it is not that. They are relying upon this team every day. They are sending kudos. They are trying to get them awards. They talk about them. Last week, the Cat Lab wanted to know if they could get some action on with this team. And we're like, what do you want us for? But they've gone from being the stepchild, as Chris said in one of the sessions yesterday, to an absolute intricate part of the hospital system for these patients. And if you've been in any 12-step rooms, this is not new. Someone has been doing this since 1935, and there might be a famous picture up on a wall in a club you might go to. of somebody sitting bedside, right? One person talking to another person with a different view, and it's not treatment, it's building a relationship, and you've heard that as you've gone down the panel today. So to say I'm proud of the team is an understatement. Their supervisor and administrator are in the room today to my left, but what I do know is we all do this, the entire room. The entire room does this. This is not a competition of who can do better or who can do this. This is about all of us sharing with each other the things that we find that are working so that we can replicate and make it better and save more lives. That's the entire point. So maybe while we compete in the rest of our lives, this is not the place we should compete. This is the place where we should build with each other and do better. Y'all got me riled up on the way down, so I'm just saying. So I do want to explain some of the stats really quick, though. So the first thing is I'll say the whole number. I'm not going to, about this much or about that much. 5,495 human beings since this pilot started have been touched by this crew. That's a lot of humans. The reason you see that almost double the number of referrals, because each referral we count separately. So if the referral is for mental health, substance use, domestic violence, or homelessness, each of those humans can get up to 4 different referrals that the same team is going to take care of for them. So that's the number of the referrals. So where they started out as a SUD navigation team only, they are so much more now. And when I use the word integrated in all my programs, whether it's crisis or ECM or street outreach or jail inreach, integrated to us simply means we're gonna treat the whole person that's in front of us and not worry about what they have. We're just gonna let them tell the story, and then we're gonna do the work to guide them in the right direction. So 5,495 humans in this program. 24% of those humans took us up on a direct treatment referral. That means that they let us do an ASAM, a mental health screening. They let us connect them to a treatment program, and they made it and they landed. Of those 24%, another 49% met the HEDIS metric for engagement. We talked about engagement. The big number I want to do on this slide before we move on, because I know we're short, look at the number 17. 17 is the average number of days that when these humans landed in a treatment program, that they went to treatment that day. That's success, right? Trying to reach this population that never walks through our doors, that we never see in our clinics, we may never even see on the street, but ended up in the emergency room or the hospital for a medical condition, hung out with you. On an average of 17 days and 30 once they landed. It's huge. So without that, let the team tell you a little bit more about what they do before we move on to a different subject. So let's go. It worked.
Mental health and substance use is at the forefront of what is going on in our communities nowadays. Patients come in here from all dimensions of life. Individuals that are suffering from alcohol withdrawals, opioid withdrawals, benzodiazepine withdrawals.
The BHI gets informed of a patient in need of our services through a few different ways. We've developed relationships so social workers could easily pick up the phone and call us. Maybe an attending would call us. But we also get most of our referrals through the EPIC. It's a smart phrase, so we pick up on an alcohol and drug or a behavioral health consultation. And that's where we start. We review the case, look at the immediate need, and then we go at bedside and meet with that patient and let them know that they're not alone, and we make sure that we meet with them, we screen them, find out where the greatest need is. If that patient navigates their treatment, we just walk beside them and help get them where they need to be at.
The screening tool that we use is called the ASAM. And it stands for American Society of Addiction Medicine, and that helps us determine level of care. At that point, we determine whether they're suitable for treatment. And like I said, we just meet them where they're at and see what we can do to help.
Well, I was, homeless, and I was having a difficult time. I didn't have dad in the picture. a baby, and I decided to, be honest with them and just tell them like I need help. And honestly, I was already doing outpatient, but I just had a relapse while I was pregnant, and I just wanted to, get clean. They also support me. They keep contact with me. I update them what I'm doing, what classes I'm attending, what certificates I've got, and they, praise me, and like that's extra like support. And not only that, it's motivation to me, because honestly, like when somebody tells you like good job, it makes you like want to do better. I'm currently in the MOMS program through RUHS. I'm also in Family Preservation Court with Judge McGuire out of the Juvenile Court in Riverside. I just finished my anger management. I already finished my triple T parenting and also my nurturing parenting. Sometimes we make mistakes. But if we can't get honest with ourselves, then we're never gonna get out of like dark hole you're in. And sometimes I just felt ashamed, but if I wasn't able to get honest, then I wouldn't be able to ask for help. Because it's okay to ask for help. That way you could catch, the problem before it just leads on to where, let's say, I wouldn't even have my baby today.
So a special piece to that is that they also have a follow-up team connected that's not counted in the hospital floor workers that then follow, especially these perinatal consumers outside the hospital. They continue to get their perinatal care, if they so choose, at the hospital with our primary care. They go into residential treatment if that's where they ended up, and then they continue care coordinating them all the way through regardless of the provider they go to. So it was very cool, and thank you for our team that put the video together. Secondarily, the next one, go super quick on this, is the Sobering Center. This was our first attempt at a Sobering Center. We will be having another one that we've coming up. But again, let's just point out a couple numbers. I want to thank the counties that let us come tour your own Sobering Centers. And this is the part what I mean about learning. We went and we toured 3 different Sobering Centers. And one of them was very active in explaining to us, don't hope for the best. This won't work very well. The police in the community will not like you. And less than 10% will connect to treatment. And they were honest about that. You were honest about that. And so we took that information into the design of ours. We did pair it with a residential and withdrawal management treatment clinic on the same site that the same contractor runs. But we heard the warning. We also heard the complaints from the city. You must do this, you must do that, you must transport them back to where they came from. Do not let them walk out. And so we took all of that into the construction and design of the program and the contract, what we had expected the contractor to do. And then we went a step further and we actually took county care coordination teams and planted them inside the facility. And so all of that put together, we'd like to, boast right here that 70% connection rate. They complete, and then another 39 connect to treatment, whether it's residential or whatever. So again, the stats kind of speak for themselves here. And the city, imagine that, is very happy. The police are very happy. But most importantly, our human beings are getting into treatment. One of the numbers that you'll see a lot of duplicates. I do want to tell you that on the duplicates, of the first time they came to the Sobering Center, 1,179 agreed to treatment. But what happened on the second or further tries that they came, we had another, over 900 patients take us up on it the second time. Motivational interviewing works. Love, care, and compassion works. And to steal, yeah, we're out of time. We're out of time, so we'll see if we can do it in 30 seconds. Stealing Gary's 95% thing, we don't call it that in our place, but it really is a great press forward for us to kind of wrap around, I think. And we have other pilots coming up because of what happened with our first pilots. People hear about it. Other medical centers want to pay us to be in their facilities to do this. in the navigation. They want to pay us for pieces of what we're doing, building a secondary sobering center. And the Riverside City pilot, just to mention, is the city is paying us with opioid abatement funds for staff that will be running 7 days a week with their city outreach teams and police department for any non-Medi-Cal billable portion. And so they are a fully funded team. And our thought is, why not now talk one of our NTP providers into sending a mobile unit somewhere we can bring our patients to do a little induction on the street. And I know we're out of time, so I'll shut up. Back to you, Gary.
All right, thank you so much. Clearly, we are low on time, and so I think we'll skip over the tabletop breakouts and maybe have time for some questions. And I think there's folks with microphones.
A quick question. And one of the slides from
Testing 1 2.
in the slide that was from Nevada County, it had like a vending machine with all these white bags, and I never seen that, and I didn't know. I was curious what that was.
Thank you so much for asking. It's essentially a harm reduction vending machine that we partnered with our managed care plan to get. And so anybody with a Medi-Cal card can get a code and for free get any of the supplies in there. And it's everything from test strips to condoms to, I can't remember what all else is in there, but tons of basic supplies people might need that are harm reduction or just well-being related that are free for people with Medi-Cal. It's pretty amazing. We have a few of them.
Thank you. I have a question over here.
Thank you for this presentation. Are those who are unable to engage included in the group of those not interested in services? And how do you help those with severe substance use disorders who are too cognitively impaired to engage?
I think that's a good question. Fundamentally, I think it comes down to what's important to that individual, right? And it's kind of starting from there. There are a lot of different approaches to, engage people, including those with cognitive disorders, whether they're because of mental health conditions or, other conditions. So I don't know if others have perspectives to add, but to me, it's about, everyone has something generally that they care about. If we start there, it's hard to go wrong.
And I would just say that, like everything, even when we're talking about homelessness, right? We go out and we say, hey, come on in. We have a space for you at a shelter or wherever it is. These people are not dropping what they're doing just to come follow you, right? We have to keep at it. So I think perseverance is the biggest one there, especially for people who might have some cognitive issues going on, that we just keep at it, that we keep going out there. Bring them a cup of coffee, bring them whatever it is that will, a bag of chips. Just keep doing that because, again, like Ryan was saying, what we've all been talking about, it's about the relationship. That's the big piece, is that relationship that we don't spend as much time on as we need to.
And I think I would just add that for us, we're very concrete about our expectation with our provider partners, and they're all aboard, is that, taking that no wrong door approach very seriously. So if they end up at the wrong place, that staff that received them, let's say it's sobering center, but they really needed mental health urgent care or crisis residential treatment, they need to take them over and let them know they're coming, and we make that happen. So it's the continuum build out to me, is if they're gonna ask for some help, we better be able to provide it, the right place at the right time. So.
I have a question back here.
Hi, I work in Orange County, and I hear you saying you need providers, I have a group of providers, but our problem is we can't get into the managed health care plans. How do we do that?
So Mark is up here in the front, and he's here at this table. He can tell you about that. I think it is difficult to work with us in the county, so I'm just going to be honest with you. It is difficult. And each county is different because each board of supervisors, a legislative body, determines what criteria a person must have. But in Orange County, we are open to working with anyone. I mean, we've had some issues in the past. We're going to give people a chance, and we hope that providers give us a chance as well. But Mark Lorenz is up here in a white shirt, and hey, Mark, pop up for a second.
Right here.
So if you guys connect, that would be great. Just look at this dating happening right here. It's like speed dating. Perfect. So, yeah, please talk to Mark.
This may be common to other providers. Every now and then, or very frequently, we have clients or patients who come in who are cognitively impaired, whose primary motivation for treatment is housing. They come into residential treatment, experience a measure of recovery, are discharged, and within a week relapse in a sober living environment. They are released from their sober living environment. They come back into residential treatment. They receive a measure of recovery. They're released. They go back into the community, into an outpatient program. They relapse within a week. They come back into the residential treatment program. And so we have, 6 or 7 treatment episodes in residential treatment. And my question is, either we're really bad at doing what we do, or the challenges for some people in this population are so significant that it requires a great deal of patience and resources in order to help them to initiate meaningful recovery. Do you have any suggestions or advice? In the back of my head echoes waste, fraud, and abuse as this person continues to come into treatment.
Yeah, thank you. And I think that'll probably be our last question, but happy to talk more afterwards for those who have other questions. I would say, as we know, addiction is a chronic and relapsing condition for most people with that condition, right? And so, from my perspective, the fact that someone may cycle through various levels of care or recovery residences that can be a reflection of their condition. What I would challenge our systems with is the extent to which we introduce what I call hinges or any kind of disconnection in those services, right? And specifically what I mean is whether it's in recovery residences or whether it's residential settings, in the future there may be opportunities to retain someone in the setting that they're in as opposed to having them kind of move. That's one of the things that we're looking at with evolving discharge policies, right? Is where we reduce the number of instances where someone has to leave somewhere, get readmitted to some other place, because that creates a sense of discombobulation in the clients that we serve that ultimately can result in them dropping out. So, anything else? Okay, thank you.